So briefly, I want to introduce this plenary. I think in this room, we would all agree by now that a healthier Washington is one that is capable of serving whole person health needs, whether they be physical health, mental health, substance use disorder related, and as many have already mentioned, and I'll mention again, oral health is also an aspiration. So by purchasing and delivering care in an integrated fashion, the state will realize a more equitable system that provides people and their families with high quality physical and behavioral health care in a timely way and in an appropriate setting. So this panel, in just a moment, will explore where we are on the road to 2020, a date that is very significant in that the legislature and governor have mandated full integration for Medicaid by that time. What challenges and opportunities are ahead in integrated delivery and engaging the community in this work. This discussion will also highlight some models for holistic health that already exist and have long existed in this state. So briefly, the panelists that will be speaking to you. First on my left is Senator Linda Evans Parlette, someone who many of you will be familiar with. As she is wrapping up her career in the legislature, she has decided to take on the task of leading the Accountable Community of Health in North Central. We applaud her for nearly 20 years of work in the legislature, championing health policy issues, and it's great to have her on this stage. To her left is Peter Adler, President and CEO of Molina Healthcare of Washington, speaking specifically to Molina's experience in Southwest Washington as one of the first regions to implement, fully integrated managed care. And to his left is Dr. Peter Rutherford, CEO of Confluence Health, who provide us his leadership perspective from North Central Washington as the dominant provider health system in that area, and in terms of how this integration is affecting their system of care. And to his left, we have Charlene Nelson, who is the tribal chair of the Shoalwater Bay Tribe and serves as the tribal delegate to the American Indian Health Commission. As we know, and she will tell us more about, tribal health systems have long taken a holistic approach to the physical, behavioral health, and other health needs of the populations they serve, and I'm excited to hear what she is going to share with us. And finally, Bunk Moren is the Director of Community Services Northwest, a behavioral health provider in Vancouver. They have borne the brunt of being the first in the state to move this concept of full integration forward, and he'll be sharing more of his experiences. So without further ado, I'll get out of their way and let him take this over. Thank you.
Thank you. So, does it sound right? Yes, no, okay. So Nathan's sort of given me a script, which I've adapted a little bit, but I'm going to read that to keep us on time, and then I've been given 4 questions to ask our distinguished panel, and we look forward then to an informal dialogue. So we will be talking about supporting systems that serve the whole person. A healthier Washington serves the needs of the entire person, physical health needs, mental health needs, and substance use disorder needs. Washington State's goal is to purchase and deliver care in an integrated fashion. For decades, we have functioned in a system that separates the head from the body. And as a registered pharmacist for many years, practicing in multiple retail settings, I have witnessed that firsthand. Talking about all 3 components of integration, Medicaid, financial integration, clinical integration, and linking to the community to achieve our whole person care goals is easy. Talking about it. Delivering the end result, perhaps, is not. That is why the Accountable Community Health group that I represent has chosen as their #1 project working toward this whole person care with all the provider groups in Chelan, Douglas, Grant counties, and Okanagan. There are differences of opinion as to what comes first, the financial integration or the clinical integration. I wrote that, Nathan didn't. The North Central Accountable Community of Health is launching a whole person care collaborative with the goal of integrating the clinical delivery of physical and behavioral health services through team-based clinical care. We continue to define and refine what this means. At the same time, we await to see what the details of the 1115 waiver are and how they play into helping us link public health and community-based organizations to the financing and delivery system to ensure all factors that impact a person's health are addressed. The legislature in 2014 mandated that all regions of the state must fully integrate physical and behavioral health purchasing by 2020. Southwest Washington, as you heard, launched integrated purchasing in Medicaid in April of this year. North Central Behavioral Health Organization intends to go next as a mid-adopter of fully integrated Medicaid purchasing by January 2018. This includes Chelan, Douglas, and Grant counties, with Okanagan County participating in 2020. The remaining regions in Washington state must come on board by January 1st, 2020, according to statute. This is truly an aggressive time frame, and I'm sure some may try to change this date in the 2017 legislative session. On top of all this, there's an aggressive time frame that the state has laid out for value-based purchasing. My hope that the region that I continue to represent as the state senator can move forward with a positive attitude while at the same time recognize that we have a lot of work to do. The integration of mental health and behavioral health really has just begun, and bringing physical health into that fold is a challenge. The good thing about North Central Washington is that we at least continue to talk to each other. Meeting the needs of the entire person is the right thing to do. So we're up for the challenge and we'll see how it goes. And now I'm going to start with a few questions, and I'll begin with Chairwoman Nelson. And the question is, we know tribal health systems embrace holistic health models. What does this look like for the Shoal Bay tribe? How does your recent Robert Wood Johnson Foundation Culture of Health Award advance an integrated approach even further? And what can the rest of the health system learn from the tribal approaches? Charlene?
That's a lot to remember. Before I begin, Marilyn Scott, where are you sitting? Are you here?
Over here.
Okay. We are elected officials, and I'd like to recognize her as an elected official. All tribal chairs and consuls are elected from membership of people, not federally, said you're the chair or something like that. So I thought we should clarify that before we begin. I'd like to honor each one of you before I begin speaking, because you are coming here as health officials that are trying to make a difference. My only suggestion to you is put away the I and bring on the we, because that's what you have to do. You have to put away the I. Shoalwater Bay Tribe has come a long ways toward health. It's very, very important to a tribe to be healthy. It's also important to us to have people around us who are also healthy. That makes a strong nation. It isn't, again, I, it's we. We will do this together. So what are leaders? So you're all leaders in a way. So what's a leader's top two goals? Health and safety. Guess what? I can put anything under there. What did we do as a tribe? We worked a long, hard time, and I would invite the ancestors of us all to come in and witness what we're saying today and what we're doing today, so that they will know that what we do will be real. Under health, we now have a wellness center. The wellness center looks at the whole person. We have a doctor, physician's assistant, two dentists, because if you know anything about rural care, sometimes people don't get dental care. If the person doesn't feel like smiling because they don't have any teeth left, it makes a difference in how the whole person feels. Oh, I'm hitting the microphone. By the way, I hate microphones. Our wellness center is open to everyone. Our tribal people, the people around us who want to come, Medicare and Medicaid. Because what we believe is it is important to be well, no matter where you are. If you look at keeping people well, it's much easier to keep people well Does it make them well? Think of that. I believe in individual responsibility. How do you teach individual responsibility? It has to come from the individual. We're talking about money. Yeah, I know that's important. But guess what? Money rules sometimes. It allows oil to go where oil shouldn't, or people not give the services they should give. We have to go beyond that. We have to sit and look at one another and talk. It's important for an individual to be employed. Money coming in helps you to support yourself and feel good about yourself. Social, family, that's important. You need some kind of connection. And if there isn't a connection, you make one. You get something within the community that brings people in. We do a nutritional lunch. Nutritional lunch can bring anybody in. It's a class too, but there's food there. You get ties. Somebody says, hey, how are you today? You need that. Safety. Safety is in a lot of ways. Safety is important. Safety in your own home, in your own nation. By the way, there's 29 federally recognized tribes in Washington State. And I'm drying out. If somebody wants to give me water, I'll wind this up. Thank you. Safety is a lot of different kinds of things. It can be worrying about wave and wind action, which means something we live right on the coastline. Many tribes do. It's changing our coastline. If you don't believe there's climate change, come and visit us. We'll show you what climate change is. We need clean air. We need clean water. Water is more precious than gold, truly. We need policy and procedure, which we are moving into. We've done a complete streets. We actually were going to do a request, a grant, but then we found out after we'd written it, the tribes could not apply. But we went a long ways because what we talked about is we want our streets to be culturally appropriate, because in our nation, culture is what brings people back. You need to look at that, whether we as Washington State have a diverse population. Honor every one of those people and their culture. And it's good to know that's your neighbor, that's your friend. Let it be important. When we received the Robert Wood Johnson Award for the Culture of Health, what they looked at was what the total. I don't think any one of us who sit in the Pulling Together for Wellness group, by the way, Pulling Together for Wellness, don't bring any silos in the door. I don't want them, and no one else wants them. You go in there as a real person, and you're all equal. There is no one that's going to stand up and say, I'm above everybody else. Anyway, at this level, the Pulling Together for Wellness is where we started. But things had started before that. And we had a wonderful young tribal member who's employee and also in Pulling Together for Wellness, actually entered us in this journey for this award. And she put it all together from 10,000 years before to now, from when we lost babies and didn't know why, to now. And the culture, the change, the things that we are trying to bring back are what are the most very sacred and important things to us. Awesome.
Thank you. Thank you very much. So this question is for Peter Adler from Molina and Bunk. Southwest Washington launched fully integrated physical and behavioral health purchasing in Medicaid in April. What challenges did you encounter, and what has been successful, and what surprised you? So Peter, we'll start with you from the managed care perspective, and then Bunk from a provider perspective.
Thanks. Good morning, everybody. I want to actually start, interestingly, we did not collaborate on our notes, but I wrote down 5 things that I want to respond to very quickly. Humility, collaboration, focus, challenges, and model of care. And so I'd like to beautifully, but by coincidence, start with humility, as Chairwoman Nelson just shared with us. Molina's experience, our experience in southwestern Washington has really been and continues to be a journey of learning. We thought we had a lot of experience with integrating behavioral and physical health, whole body care. We have all over the country in many other states. We did in Snohomish County for 8 years with the WMIP pilot, and we did learn a lot. But when we went into this, I can now say we didn't know what we didn't know. Today, 4 or 5 months into it, I think we're at a point where we probably know what we don't know. But I would be misleading you and to say that we've got it figured out. We're at the beginning of the journey, and it has brought us to a place of both inspiration and humility, which will frame my other comments. Some of the things that have gone very, very, very well is the level of collaboration that has been unleashed through the early integration work is nothing short of remarkable. For us members, we now convene case conferences where behavioral health providers, substance use disorder providers, chemical dependency providers, juvenile justice system, when that's necessary, state hospitals, county, ACH, people are on the phone. It's remarkable now that the conversations that can happen in service to the member being at the center. Example after example after example. The second example has been between CHPW and Molina, the 2 health plans who were given the opportunity in this work. I have to say CHPW has been a remarkable partner with us, and we've agreed to standardize all of our administrative processes so that no longer will providers, will members, will the community in southwestern Washington have different policies and procedures that are administrative in nature. That's not where we want to compete. That's not energy well spent. And it is certainly, although has always been well intended, collaboration has led to some very remarkable breakthroughs that have gone very well. Another example happened just Friday, which is the ability to deal with not just member or person-specific challenges, but community-wide challenges. The opiate addiction problem, something which has certainly is taking this entire country by storm right now. We convened and hosted an opiate addiction seminar and day, all day on Friday, in which we were able to bring together the entire community, not just providers in the community, but brought in UW, brought in research from OHSU, and a number of others to take on this problem as a community. That would not have been possible in the absence of the kind of environment that now exists with the early adopter. In terms of focus, my second area very quickly, the behavioral health providers, was appropriate concern on approach that they would get trampled or misunderstood or in some way harmed in this process. It's been our experience with a great deal of focus in the behavioral health community, and I'm including substance use and CD providers in this, my comments, have been nothing short of wonderful. They were scared, and they had every right and reason to be scared because the world was changing very quickly, and the parties with whom they were working and ultimately paying them were changing. Bunk is a representative there who will speak in a moment and will speak from the behavioral health community's perspective. But one of our ahas has been in the early adopter region is that there needs to be as much focus on the physical health providers as the behavioral health providers, because the amount of cultural change that is necessary in the physical health world to look at whole person health and to collaborate is as great as in the behavioral health world. And if anything, behavioral health providers have actually been leading the way in role modeling. So kind of an aha for us that we didn't expect. Outcomes. Everybody's excited about and wants outcomes. Population health is, third learning for us, is a long-term proposition. You don't change the health of a community overnight. And although there's pressure, understandably, from all the other regions in the state to know what's going on, what are the outcomes, the legislature who's investing in this and took a bold step forward, but it takes time. But I will share with you that the early indicators are very promising and very inspiring right now. We're beginning to see emergency room utilization begin to slightly decline. We're beginning, it's only been 4 or 5 months, to see acute care hospitalization begin to decline. And we're beginning to see outpatient utilization go through the roof. Exactly what we wanted to see. We don't know if these are sustainable trends yet, or if we haven't been in it long enough. We don't know if there's enough money on the table to fund the pent-up utilization and demand that we are now finding through this process. But early indicators are really very promising. What are some of the challenges that we've encountered? One is, this was known, but the import of it can't be understated. The unavailability and the absence of standardized data, of standardized information, the absence in the behavioral health community of standardized EMRs and definitions of care. The absence of historic information of encounter-based data that's very common in the physical health world upon which to do disease management planning. The tribes, the Cowles tribe is the one tribe in southwestern Washington. Talk about humility. The tribes, in particular Cowles, because that's the tribe we've been now working with, has figured so much of this out. We didn't engage the tribe there as early as we could have, but oh, are we doing that now? So much learning there and wisdom that has not been part of the infrastructure of, if you will, traditional and non-tribal medicine. And then the final point model of care is value-based purchasing and changing the financing. That's a means, it's not an end. It's an enabler, it's a culture shifter, but in and of itself is not integrated health or whole person health. It's about a model of care and changing the model of care that the financing system and having a single organization, the MCOs, be in the position to be able to move dollars from acute care and to outpatient is an enabler to changing the model of care. And we still have work to do. So that was helpful.
Very good. Thank you, Peter. I want to just mention a little bit about the organization I work for to give you an idea of the lens of our experience. So Community Services Northwest is a DBHR licensed behavioral health facility. We perform outpatient substance abuse counseling, outpatient mental health counseling. We have a medical department. We also have a supportive housing department that has HUD contracts, county and state contracts to help people with supportive housing, and we also are a landlord. We have about 12 units of housing. And there's lots of other little pieces to our organization, but that's pretty much the scope of what we do. We have about 120 employees and 4 clinics in the Clark County area. So that's the lens through which we've experienced this healthcare integration effort in early adopter. So our experience is, I would have to go back a couple of years because I was lucky enough to be involved when early adopter was just a twinkle in the eye of some folks and was just getting explored, having it passed through the legislation, and remembering the fear that spread through the provider community at the time, the reluctancy, as Peter mentioned, understandable and certainly deserved anxiety regarding the change. I remember experiencing that. I remember the consultation that was provided to us on various levels, which expressed sort of a spectrum of experience in the country of where this has gone well and where it hasn't gone so well. What were the distinguishing characteristics that might lead you to believe you're heading in the right direction? I remember going through all of that for a period of time. I was also lucky to be the co-chair in our provider alliance down there, so all of the DPHR providers meet once monthly and go over things in general, but certainly early adopter. So I remember where all the providers were on that spectrum as we roared ahead towards April 1st, 2016. And then sort of contrasting that to today. And I can say that in a nutshell, I would say that the experience it's gone very well. It's been a great experience. I think if anybody rewinding back to those early days could be told that this is where you'd be 5 months into early adopter, the providers would have taken it as a heartbeat and been very pleased with that. There's obviously lots of nuances to it. There's been hiccups and things like that. But I think in large, the recipe that was made and the parties involved made for a very successful transition. And I think the pieces of that were very key were leadership from the county, Clark County and Skamania County. The healthcare authority was very involved. One example was the daily calls we had from, I believe, April 1st at 8:30 a.m. every day for, I think it was 2 months. And I think we still have them every other week. I've been a little reticent or neglectful in my duties every 2 weeks to join those still. So the issues that came up had a forum to come up quickly. Concerns were heard. There was a very collaborative spirit from all those levels, which I think supported a very positive transition. I don't think any provider felt like their voice wasn't heard, their concern wasn't given airtime, if not addressed. I also think that the plans that were selected, Molina, Community Health Plan of Washington, and Beacon, had a very collaborative spirit about how they approached it, which is probably the most important element in my mind. They were down early and often, meeting with lots of providers, meeting with the group. They were very gracious in using soft gloves with us, in my opinion, and saying, you won't have to change a lot to get through this transition. We'll take on the bulk of the change in our systems. They continue to pay every credential type that we have exactly the way, or almost exactly the way we've been paid in the past. So for anybody who works, we're a nonprofit, I know there are for-profits in our network, but we typically have very lean administrative structures. Your IS super user is also your billing supervisor, is also your support service manager, your clinical director is also your executive director, your executive director assistant is also your HR supervisor. Everybody's doing 3 jobs. So there's not a lot of wiggle room to take on a lot of work leading up to a transition like this. And because of the health plan's approach and not having us overhaul our systems, I think it was very manageable for the providers to get through this financially and still have billing go out, coding go out, submission of claims, have people get paid, not have to go through a ton of administrative work, getting providers credentialed, that sort of thing. So a lot of kudos to the plans for that. Hoping that continues, that graciousness, I'm sure it will. But that's largely in a nutshell been our experience as far as the build-up, the transition. And the other last piece I would add in there is I've been in Clark County working in this network at this organization for a little over 12 years. I started on a PAC team, for those of you who are familiar with Washington PAC teams. So I had a role where I was involved in housing, I was involved with medical, we had a substance abuse counselor on the team, mental health professional, a peer counselor. So I started as a very integrated model when I started 12 years ago, programmatically. now I'm a bureaucrat. I sit in meetings with representatives from health plans and the county and other systems. And what I can say now is those meetings that I'm in now reflect my experience when I entered the system. The convening that is happening in Clark County, where housing is at the table, the county is at the table, the health plans are at the table, there's an investment, there's a desire to understand where the gaps are, what's working, what's not working. That is significantly different than it was a year ago. And that's no fault of anyone, there's no judgment in that. I think the platform is just been set where, for whatever reason, the convening of these social determinants, all the things that can affect healthcare outcomes are at the table now. And that's, I think a good start for what we're talking about here. We're pivoting from financial integration to clinical integration, or a model that'll work. And I think the schoolwork, the homework that has to be done so that the plans can support that in a positive way is being done right now. I'm very satisfied with that. And I know, again, as the co-chair of the Provider Alliance in Clark County, I know that reflects the feeling of all the providers down there, the TPHR providers. We all have our own story in this, but I think the consensus is pretty much that. Yeah.
So this question is for Dr. Rutherford. North Central is next as mid-adopter of integrated physical and behavioral health purchasing and Medicaid. What challenges and opportunities do providers face in making this transition? And how do we support this clinical transition, and how do we ensure its sustainability?
Well, thanks, Senator, and I think that's a huge question to try to answer.
I didn't write it.
But it's one that we sit and think about and talk about a lot. And I guess I start from 30,000 feet, but I really struggle a lot with what's at 30,000 feet and what's at 6 feet. And from 30,000 feet, I'll argue a lot that this integration really gives us an opportunity to do the right thing and to drive to what you talked about, Senator, as far as whole person care. Because I think it just is the right thing to do. And I think all of us in our organization and in other provider groups in North Central Washington, both from a behavioral health, a substance abuse treatment, and from a physical medicine, recognize that we have to do better. That we have to be more available, more responsive to the needs of our patients, who in reality are our community members. So why are we doing this now? Or why are we in support of doing this now? I'm going to argue it's because we have an opportunity to write the recipe for what this is going to look like in North Central Washington. We're not going to get handed the Betty Crocker cookbook on January the 1st of 2020 and say, here you go. So we are hoping that there's an opportunity to engage with the state, with the various provider groups, and develop a collaborative model that works. So why do we struggle? Well, I think there's lots of struggles, but I think as Allison pointed out in the first session this morning, this is a humongous change. I will also, as I look at this, think from a basis of change management or whatever, we've got one opportunity to do this right. And we need first to have a common vision, a common pathway for iterative improvement, and we need to make sure that everybody is engaged and aligned in this. And that isn't just the physical medicine patient or providers, it's not just behavioral health or the substance abuse providers, but it is every patient and every community member in our region. And that's going to be a huge task. The other is it's inevitable, it's coming, the legislature has passed the law, and yeah, we can argue about whether they're going to put it off past 2020. I think we're just delaying the inevitable, and it's coming, and it is the right thing, and we should just get down and get to grips with it. As I look at it from a Confluence Health perspective, though, we're being asked to look at health from a different definition. We've commonly in the past looked at it from an acute illness or acute condition treatment. But we're now being asked to look at health from a perspective of basically wellness, social well-being and physical well-being. And that's a big difference. We're being challenged from a financial perspective in our payments for healthcare, which, if you look at the Institute of Medicine, says that healthcare is about 10% of the health cost. There is a huge environmental piece, there's a huge behavioral piece, there's a huge social piece. Those are in many ways outside of our control, but we have to engage those pieces in this discussion to make this work. The other thing that I spend a fair amount of time just kind of reflecting on as a nonprofit organization is who owns us. And in reality, it's our community that owns us, it's our patients. And that we need to be responsive to them as we figure this out and as we move forward. So I think if this is going to be successful, and I want it to be, and we will make it successful, we've got to get every physician, practitioner, nurse, healthcare staff member engaged in this, and our patients. And I will argue, as Peter said, the way that we're going to do that is to define the care model first, and then figure out the finances. I think if we allow the finances to lead this, we will fail, or have a very high level risk of failure, because we won't have the right engagement and alignment of the people providing the services or receiving the care. So to me, there are kind of three pieces in how you do that. There's first the why, then there's the what, and then there's the how. And so from a why perspective, I think we know we need a better system. We're looking for a better system. And to the comments that Mr. Cooper made earlier about not triple aim, but quadruple aim, we have to look at where we're at from a provider and staff perspective at this moment. And if we don't do something in this that intrinsically improves the value for them to come to work every day, we're not going to get there. And I worry about the intrinsic rewards that we have in healthcare at this moment. Then the other part of the why in this is we are part of the community, and we are responsive to the employers who provide jobs for people in our community. How do we keep the health cost of healthcare down so that those businesses remain viable? How do we reduce the use of resources in healthcare so that we've got them to spend in other places like education or infrastructure that are suffering at this moment? So then the what, to me, is that we need to have a common vision that we can all agree on. That needs to be in our organizations, that needs to be regionally, and I argue needs to be statewide. If we don't have a vision, if we don't know where our true north is, if we don't know where we're heading, we're going to waste a lot of time and we're going to waste a lot of effort. Then lastly is the how. And we're spending, I think, a lot of time talking about the how at this moment, but are we all comfortable that we have the why and the what well-defined, well-communicated to everybody in all of our organizations? I think this clinical integration is going to be really hard work. While there are a lot of good integrated care models to look at, we've got to learn about them, we've got to figure out what's going to work in our region, and then implement it. There will be huge cultural changes that we need to overcome. There are a bunch of new relationships that need to get built between various providers and aspects of this whole issue of health. Those are built on trust. And if you haven't worked with somebody and you don't have a relationship with them, you don't have trust. And how do we get that trust built? That's going to take time. We've talked about the data and the analytics here, but I think we need to first define how are we going to know if we're successful. sure, we've got these 54 metrics out there. They are a large number of process metrics. But at the end of the day, how are we going to know we've really moved the bar from a clinical and a care perspective? Then there's the financial integration. And as Peter pointed out, you know, where his organization, and I presume CHPW as well, has taken a huge leap here and said, we think we're going to have some savings over here that'll help pay for them. But that's a huge leap and a huge risk that he has put his organization, and CHPW has put their organization in. But these finances, to me, need to be agreed to and acceptable to everybody. The integration efforts can't sink the ship. Many of us, at least in Confluence and many other parts of this region, we're the safety net in the community, and we can't quit operating the way we are while we say we're going to turn off the system for 2 months or 3 months and rebuild this thing. The current behavioral health dilemma for us is huge in finance. It's utilization based. So if you don't utilize, you don't get paid. If you don't pay, you don't utilize, and you can see the toilet flushing. Whatever we do, we need to reset the bar, I think, and look at this from a prevalence standpoint. Here's what the need is. Here's what you're going to have to do. Our obligation is to say, here's the care model that we've developed as a region. Here's what we're willing to be accountable for as far as performance. Will those who fund this have our back to allow us to do that and not go broke? And I think that's going to be another huge discussion that we have in our region over the next 14 months. I don't really mean to sound like Debbie Downer, but I got a lot of worries. But I think this is an incredible opportunity. I think we will do this right. We need to do it right. But it's going to take a lot of work and a lot of people at the table putting their old habits aside.
Thank you. So I have one last question, and then we'll open it up to the audience. So this is for any of you. Why haven't we had whole person care up to this point? Why now? And what lessons can we learn from systems that are already integrated to guide our way moving forward as we scale whole person care statewide?
I'll take a first stab at that. Why now, and why haven't we done it? I think one of my favorite many quotes from Winston Churchill is that all people love change until it applies to them. So the change, it never really begins to take place until the status quo becomes more painful or more disruptive than a common vision. Why now? I think if we're all honest, and someone wisely asked the question in the room earlier today, what we're doing, if we're honest with ourselves today, status quo isn't working. Look at our statistics as a country. It's true in the state as well, of what we spend on healthcare and on the measurable outcomes that are available, despite best efforts, despite wonderful providers, despite all good players. We need to change course because it's unaffordable for the outcomes we're getting. I think in terms of some examples, the final part of your question, at least that came to mind, I think in this state there are 3 examples that are very worth looking at. One has been mentioned, and that's the tribes. The tribes have had, as I understand it, and I'm coming to learn, a very whole person and holistic view of health, as Dorothy Teeter's this morning, as distinct from healthcare. Second is the FQHCs. The FQHCs have had oral health, have had behavioral health, have had physical medicine, so many of the pieces of the puzzle under their roof for so long. We haven't We as a system haven't worked with the FQHCs in silos, but in many of our FQHCs, I believe in this state today, are some beautiful models. And then the third is, in terms of large scale, is I look at group health, who as an organization worked within Confluence as well, a capitated environment where, as providers, there has been a very holistic view of taking risk for, if you will, and responsibility for the portion of health or healthcare for which they have been capitated. Group health, sorry, become Kaiser. In group health's case, and in Confluence, is by way of example, behavioral health has only been part of the puzzle and has not fully been included. But living within an environment of receiving funds and being responsible for the outcomes of care are something that those organizations have been doing for many years.
I enjoyed what you just said, and honestly, we didn't even talk to each other before this time. But he said something that's very, very important. Another person I'd like to quote, or it's not going to be an exact quote, is a person you probably read about. If you do something over and over and over again and it doesn't work, you need to change. Einstein. So I look at what we do now, and we look at the whole person, and it's in one building. I don't know that all communities can do it that way. But we have behavioral health, addictions, diabetic care, nutrition, our physicians, and dental. We try to serve the whole person because, one, we want to make them well. Two, if we can keep people well before they get sick, guess what? We save a lot of money. Save a lot of money. But anyway, when you were talking, I thought of that. Others?
I'll just add, I think we're at there are several things that have, I think, brought this on. First, the complexity of the care that we are able to provide is much more than it was when I started my career 30 years ago. Patient expectations are different. And people providing the care are trapped in this place now of rising expectations, rising complexity, and not enough time to do it the way we've been doing it in the past. So then you cut corners and you go home feeling like, I survived the day, but I really didn't make a difference. And so you've got that basis. And then I will applaud the legislature for saying, we're going to step out and we're going to make this happen. And by doing that with Medicaid, which for Central Washington, North Central Washington, is a large component of our population, it's going to drive this change. And I hope that the rest of healthcare comes along and healthcare funding comes along for that effort as well.
Yeah, I'd like to make one comment on that. I agree with all that sentiment. And from our own myopic perspective, being audited on a regular basis, regulations also play a role in prohibit integration. An organization like ours, and I'm sure many others, have people whose scope could cover much more than what they're capable of doing. But Washington Administrative Code or Department of Health credential scope and things like that, what has to be in a treatment plan, how often it has to be reviewed, all that sort of stuff prevents you from having one person with one treatment plan or providing something that's outside the scope of your organization. It's certainly not the whole problem, but it certainly limits an organization's ability to even be integrated within the skill set you have.
Okay, well, open time for
One or two questions.
one or two questions, Nathan says. So who's got the traveling microphone out there? This light, it's hard to see where the hands are going up. We have time for one or two questions. Here's one at the front, up here. One here and then one over here.
Thank you very much to the panelists and to our moderator. Excellent reigns of wisdom. So this question is for Mr. Peter Adler. And you had mentioned that despite the early concerns of behavioral health providers, that they were the lead in the change. So could you please specify that a little bit more if you can?
Sure, thanks. I think that with our experience has been that behavioral health providers in southwestern Washington, because of the mandate, the fundamental premise of full integration, earlier than the physical health providers came to the realization that being part of the change was a much better self-determination and path forward than being a recipient of it. I think the physical health providers, understandably, it's not about good players, bad players. There's exquisite physical health providers, traditional physical health providers in southwestern Washington, viewed this much more as an add-on to what they were doing as opposed to a fundamental change of the model of care. And that brought the behavioral health providers, and you can speak to this from a different frame, into the conversation and into the discussion much more quickly. And the second thing is the fear, at least that we, early fear experienced and heard from the behavioral health community of, are we still going to be paid? Are those big, bad managed care organizations going to pay us less and cause us not to be able to make payroll? Very Maslow hierarchy of needs worries tends to bring people into the conversation in a very earnest and a very quick way. I don't know if I misspoke.
No, well said.
So I would say in north central Washington, it's the medical community that stepped out and said, we need to do this. We probably have in the 4 counties, Chelan, Douglas, Grant, and Okanagan, if I remember right, about 9 critical access hospitals. We have many FQHCs, and of course we have Confluence. And as I mentioned, we all talk to each other, but I can assure you it's our rural hospitals that are very concerned about this, and this is why our accountable communities of health are focusing on this whole person care collaborative. We're still defining and refining what that means, but we have decided this is where we need to focus and really help as this transition occurs. There's another question over here.
Thanks. So I'm just, first of all, congratulations to Molina and CHPW for figuring out how to collaborate on key issues like standardizing administrative processes. As you go forward, this is for all of you, how is this changing your thinking about what you collaborate on and what you compete on?
Except for me. The whole question of value and putting the person at the center really causes one to stand back and look in the mirror and say, and ask what provides value and what doesn't. And administrative processes are necessary. The complexity that we're dealing with, the amount of dollars we're dealing with, require standard practices. This is all taxpayers' money. This is the people's money that we've been given responsibility to be good stewards of. And at least I can only speak for Molina on this, and I invite the other NCOs to speak, or certainly CHPW. But for us, we began looking at, we're not certain that, in fact, we're certain that having an intake form or process that's completely different between one health plan and another, developed in good faith, but independently in our silos throughout history, was not bringing value to the community. The need for an intake process and a referral process and standardized policies, procedures, that has value. But it's not an area, something that either Molina, I was going to speak for CHPW as much, it's not where we chose in this process not to compete on those things. We still compete, but it's instead we want to compete where we believe we can bring value and where there's administrative processes that are necessary but are not about value. Let's standardize it. That's at least has been the conversation within Molina.
I would say for us, where in North Central Washington, the vast majority of our pay is government pay at this point, and it's fixed. We're not competing on price. We have a fixed income, and it's what kind of outcomes, what kind of patient service, what kind of community health can we generate is where we're going to compete. We're going to compete on patient experience and care outcomes.
Well, I was told 2 questions, but I don't see Nathan. There's another question, right?
I'm out here, but if
One
we
over
have
there.
one more question.
One more
Sure.
question over in this direction. Go ahead and stand up if you want, thank you. And then that'll be the last question, right? I snuck one in.
Not so much a question, but a comment, and I just want to commend the regional and Peter as a representative from the Southwest region, that the early adopter, and the recognition of the involvement of the Cowlitz tribe, and although it may have came later, the recognition that there is a system that can blend and has done some things that recognize in the sovereign governments of the tribal nations within the various regions. And I would recommend that the North Central being the mid-adopter region, take that experience from the early adopter region and involve the tribes in that region earlier in the game. And the one thing that I do want to commend with regards to the consolidation is the importance of the accountable communities of health, the regions, to recognize the sovereign governments within the regions. And the tribal governments have responsibility that crosses over the jurisdiction of our population within our communities. That includes not only our tribal members, but those individual citizens that reside within our sovereign reservation, and that includes non-natives and other population individuals that we have responsibility for. So we are a partner with the counties, with the state, and the federal government, but we are an independent government that has responsibility, and we do have, in some cases, our own taxing system that is covering some of the benefits that the individuals that reside within our reservation. So that is just the general comment that I wanted to share with this group. Thank you.
Yeah, this is a 2-seconder, kind of a wind up. I'm standing up so you can see what I'm holding. What's the difference? Come on, somebody holler out. What's the difference?
The one on your right is a real thing.
Okay, what I'm saying is, on paper, maybe it's not real. Make it real. Make it real.